committee has brought Jason Van Stone and Melissa Kusi, who are part of the Regina Antimicrobial Stewardship team, to this health region to talk about some infections we see in hospitals. So Staph aureus bacteremia, UTIs, pneumonia, see what else they'll touch base on. So I'll let you take over, Jason.
Perfect.
Thanks.
Thank you very much. All right. So I guess first of all, thank you very much for having us out here. Wonderful to get to, I always like coming to different places across the province and meeting different people, the antimicrobial stewardship folks and everyone else who is doing all this important work. So thank you for having us. Thanks everyone for joining in on WebEx.
Always Dr. Lee, I forgot to.
Oh yes, Dr. Lee as well is with us. There he is. Hi, Stephen. Stephen's going to chat too. So we weren't sure how broad the audience would be, so I get to do a little bit of a antimicrobial stewardship intro, just so that we're all kind of on the same page. I think it's good to lay the groundwork, just to talk about how important this issue is globally and locally, and then that hopefully gives some context for what Stephen and Mel are going to talk about a little later. So I'm Jason. I'm a research scientist with our Stewardship and Clinical Appropriateness Department. Our office is based in Regina, although we've got members from across the province. So I guess we're not really based in Regina anymore. We've got people all over the place. Yeah, so antimicrobial stewardship falls in our world. So I've had the pleasure of working with all these wonderful people for a few years now. So research is my background, so I like all things sciencey and nerdy. And I have a favorite bacteria. So does anyone else have a favorite bacteria that you'd like to share? Who has a favorite bacteria, first of all? Hands up. Only me. Okay. Does anyone? Okay, here we'll start with this. Stephen, do you have a favorite bacteria? I could see your face.
Maybe, I don't know. I'm gonna say Pseudomonas because it's kind of like it keeps me employed.
Fair enough. Okay, thanks. So this is my favorite, Yersinia pestis. Does anyone know what that bacteria happens to cause? Yeah? Plague, right. This is the plague bacteria. So mine's a little more morbid, maybe, than Stephen's choice. But I'm fascinated by these things, and for me, it's the interconnection between humans and bacteria that have existed for a long time. So as we know now, this is the bacteria that causes the plague. And so really, as long as there have been humans on the earth, there have been bacteria around to infect us. This picture here is an image from a Neolithic tomb that was dug up in Scandinavia, Sweden, I think. And what they found here, so this was about 4,500 years old, the area of the ground in which they were digging. And they found the skeleton of a 20-year-old woman who had died of plague. And so this is the oldest known case that we've dug up so far of someone who's died from the plague. And so this is likely something that sort of went through her small farming village, 4,000 years ago. So the oldest known case, but of course there are much more famous versions of the plague that we know of. So in about 565, so in the 6th century CE, there was the Justinian plague that went through the Roman Empire. And it took out about half the people in Constantinople there. And so there are different theories about how it got there, right? So obviously the usual is like it's ships coming out of Egypt that had rats on them and grain ships, and they made their way to Constantinople and started spreading the plague. But more recently, there has been evidence that perhaps some of these plagues were spread into Europe by people coming out of the Eurasian steppe. So the Huns, who are often depicted as angry horse riders with even angrier horses, coming out of Eurasia and making their way into sort of the Roman Empire and bringing the plague with them. And so there's evidence of plague happening in these populations throughout that sort of Middle Eastern area. And so, yeah, just people moving around, rats moving around, things like that. And then, of course, the most famous plague, the Black Plague, the one that wiped out, half of Europe in the 1300s. And a lot of people recognize the plague doctor, the big bird bee thing. So when I was in high school, I first saw this picture. It's called The Triumph of Death. And this was something that was painted in the 16th century. So, 300 years after the plague started the most recent plague started making its way through Europe. And I was always fascinated with this because it's got so much detail and you can really look at it. It was something that I like to look and see all the things and, think about what's going on here. And it depicts sort of the aftermath of the plague and the chaos and panic and upheaval that it caused in Europe. And when you think about that, with half the population dying, that would have been a huge blow to that part of the world. And so it has a different meaning for me now after the most recent pandemic that we've been living through, and after seeing pictures of mass graves and stuff like that in New York with COVID causing issues that it has. But for me, what this represents is the real impact that bacteria have on human life. And so we can just count that by the numbers of deaths and stuff like that, but the fact that it makes it into our culture and our art. And these are things that affect people in that way, that we're making paintings about it. And all of this from one bacterium. And that's not even an antibiotic resistant bacterium, which is what we're going to talk about today. So, throughout human history, as I said, there have been bacteria around to do bad things to people. And so what this graph here is showing, just in 1900, so just about 100 years ago, the mortality, 46% of deaths in the USA, this data is from, were from infectious diseases. So if you think about that, about half of the people who died just over 100 years ago were dying from infectious diseases. And you can see that if you fast forward 100 years into the 2000s, that number is down to 3%. So that's a huge shift in what people are dying from just in that sort of century span. And if you overlay a life expectancy on that, in 1900, the average life expectancy was about 45 years, which really isn't that long. And it's nearly doubled in that 100-year span for most high-income countries to be around 80 years. So again, we've got a huge shift in what people are dying from and how long we're able to live. And so a big part of that was the discovery of antibiotics. So this is an amazing tool that we have in medicine, which has really changed modern medicine for the better, and something that we need to hold on to. So this guy here, who knows who that guy is? He's the guy who discovered the very first antibiotic. How about that? His first name is Alexander.
Fleming.
Alexander Fleming, thank you, from the Antimicrobial Stewardship pharmacist. Alexander Fleming, a Scottish physician and researcher. He was a bacteriologist. So in 1927, he goes off on vacation. I'm going to tell you the story because I like the history of science. He goes off on vacation, leaves one of his bacteria plates open in his lab, and comes back and sees this fungal colony growing on it. And says, isn't that interesting? Because he was Scottish. And what he found was this fungal colony growing there. But what's the interesting piece? Everyone can see. What's the interesting piece going on there? There's no bacteria around it. There's a zone of inhibition. So rather than just throwing it out and counting it off as a failed experiment, he looked into that. And what he discovered was that this fungus, this penicillium fungus, was exuding these chemicals into the environment to kill off the bacteria. So when you think about that from an evolutionary perspective, at the microbiological level, everything still has to compete for resources. They need food, they need space to live, all that kind of stuff. But these things, unlike animals, don't have claws and teeth and nails to fight with each other, so they use chemicals. This is chemical warfare at the microbial level. And so what he discovered was there's this chemical that this fungus is producing that kills off the bacteria and prevents them from growing in their space and taking up all their food. And so stumbling really upon this huge medical miracle of discovering antibiotics. And so throughout the rest of the 20th century, there was this explosion of discovery of different types, different classes of antibiotics. You can see a bunch of them listed there. So that's a super important change for us in modern medicine, along with other things that came along in the 20th century. But of course, all good things, there's the silver lining, and then there's the real stuff that happens. And so this graph here is just showing from sort of the 1980s on. Eventually, we start to see the growth and exponential growth of antibiotic resistance. And so this here is just showing a few. So there's methicillin-resistant Staph aureus, your vancomycin-resistant Antimicrobial, so on and so forth. This is driven by our use. It's complicated by the fact that, so if you extend that graph from the last one, after the 1980s, we really hit this development void where we really haven't, in the last 40 years, discovered any new classes of antibiotics. So We've changed some, we've messed around with the chemistry to try and make them work a little better. But for the most part, what we have is what we've got, and bacteria are becoming resistant to that. And in fact, so this here shows for different types of antibiotics on the left, when we start to see antibiotic resistance on the right. So even starting right with penicillin, first introduced in 1943 when it really started being used widespread. And it was 1965 by the time we were seeing widespread resistance to that. And so on and so forth. I mean, even things like levofloxacin, that one always gets me. As soon as it was introduced, we already knew there were antibiotic-resistant organisms out there. So this is something, it's a natural process that occurs. This is just evolution. As these things are exposed to these chemicals, they develop mechanisms to become resistant to them. So as I said, we are one of the big drivers of antibiotic resistance. Human use is one of the big things, especially in medicine, that is causing this problem for us. So here, looking at, let me get my mouse open, the months of the year along the bottom. So we're starting in January, February, March. We're seeing in blue antibiotic use, in this case, aminopenicillin use. And what we're seeing in orange is rates of resistance in E. coli to that ampicillin. So when we have high use of antibiotics, there's about a month lag, but we see high use or high rates of antibiotic resistance. And as we use fewer and fewer antibiotics going into the summer months and people spread out and don't cough in each other's faces as much, we see less antibiotics, and therefore we see less antibiotic resistance. And then kids go back to school and do what the gross things that kids do, and they spread disease, and cold and flu season starts up again, and we use more antibiotics and we see more antibiotic resistance. So we know this. We have data to show that the more antibiotics you use, the more antibiotic resistance we see. So we can affect this phenomenon with how we treat our patients and use these antibiotics in medicine. So I alluded to this, antibiotic resistance happens. It's hard to stop because it is a naturally occurring evolutionary phenomenon. So when you have your regular run-of-the-mill bacteria, these little green guys at the bottom, when you throw your antibiotics at them, they die, good riddance, and this is what they look like inside. So there's bacterial chromosome, and they've got these plasmids. So really the only difference between these guys and bacteria that are antibiotic resistant are genetic changes. So now you've got resistant antibiotics who have just little changes in either their chromosome or often in these plasmids, these little extra chromosomal pieces of DNA that they can share very easily. They're quite promiscuous with their DNA. They can share that very easily with other bacteria in the same species and even between species, which is one of the big problems with antibiotic resistance spreading. It can go real fast. So this was one of my favorites. I had to put this slide in. There was an experiment that they did at Harvard a few years ago to try and show antibiotic resistance developing in real time. So what you've got here on either side, so this is like a petri dish, but like the size of one of these tables. And on the outer edges is just your regular growth media for your bacteria with no antibiotics. So that's what the zeros represent. And so what they did was they plated their bacteria, and you can see they grow. That's what that kind of white stuff is. It grows as a carpet, a lawn, and fills up that entire space. But it has to stop where that line is because now there's antibiotics. So there's a 1 times concentration of the antibiotics in that those next columns inward. And what happens is you see these little explosions where the a bacterial cell acquires resistance and can start growing into that neighboring piece. And they grow and fill that out until they hit the next wall where there's a 10 times concentration, and so on and so forth. And so what we see, and I'll just speed this up, is you can see, time lapse obviously, but in essentially real time, this evolution happening of these bacteria becoming more and more resistant as they grow right into the middle where there's 1,000 times concentration of antibiotics. So if we put a kind of family tree over top of that, you can follow these lines of evolution from the dark blue guys on the far right or left. They go into they acquire mutation and they grow into the light blue part, and then the yellow and greens and oranges and reds, so that you can actually trace the families of these bacteria as they've acquired mutations to become more and more resistant to these antibiotics. So it's a hard thing to control once it makes its way into a bacterial population because it spreads really quickly. So antibiotic resistance is a problem, but we can do something about that. And that's what antimicrobial stewardship is for. So the big question for most people who've never heard of this is, well, what is antimicrobial stewardship? I like board games. I've had the luxury of presenting from my house over the last 2 years, and I have a huge shelf of board games behind me, so people really tune into that. But this is one of my favorite board games. It's called Pandemic. I haven't played it a lot in the last couple of years because it's very on the nose for what's been going on. But the idea here is that it's a cooperative game. So all the players play together and you're trying to beat the game, essentially. And so what you've got, there's a map of the world, and there's these 4 different bad guys, bugs, bacteria, viruses, infections that are going around the world trying to decimate the population. And so as a team, the players have to try and find cures for each of these different bacteria, we'll call them, and stop the world from being overtaken and populations from dying. So the cool part is that everyone gets their own role. So you could be a scientist or a researcher or a dispatcher or a medic, things like that. And they all have a unique power that lets them do something special in the game that the other players can't do. And then when you combine all those powers together as a multidisciplinary team, that hopefully gives you the edge to win and fight off these bacteria. But of course, the game fights back. So there are epidemics and mutation events that cause these bugs to spread and change and attack in unique ways. So it's a lot of fun, especially when you're not in the midst of an actual real pandemic. But I definitely suggest trying it out. Yeah.
Do they have the twist where people deny the existence of those 4 bugs?
I feel a future expansion coming on because, yeah, definitely there's some of that. So what I like about this is it's art imitating life, right? So this is real world problems here. Antimicrobial stewardship programs are kind of like what's going on in this game. So it's a multidisciplinary team of experts whose job is to basically attempt to slow the development of antimicrobial resistance around the world by promoting appropriate use of antimicrobials. And that's really all we're doing. So our team in Regina, we work in the hospitals, we work in the community, we work across Saskatchewan, we get to travel to exotic locations like Yorkton and talk about this stuff and spread the knowledge and education, getting people involved and trying to make a dent in this global problem by taking local action. So why do we need this? If you're not familiar with the data, here is some of it. In Canada, so these are all the provinces and territories across the bottom there, and this is the most recent data from our Canadian Antimicrobial Resistance Surveillance System report, so the CARS report. And so Saskatchewan here, there's our flag. Why do we need this? Because especially in Saskatchewan, we're not super good at it. This lowest year on record is our antimicrobial usage. So this is DDDs per 1,000 inhabitants. Our lowest year on record in their data is higher in terms of antimicrobial usage than our 5 surrounding provinces. The Maritimes have their own special problems going on, but traditionally these guys get lumped together. And so if you look at it that way, we're the 2nd highest users of antibiotics in Canada here in Saskatchewan. So we have room to improve. That is for certain. Make sure I'm not clicking stuff here. The other thing, so when we're talking hospital specific, the CARS data shows nationally that we're also seeing increased healthcare associated infections. Why won't this go away? Go away. Increased incidence of several healthcare associated infections. So or antibiotic resistant organisms. So the first graph there is healthcare associated MRSA bloodstream infections. You can see those are on the rise over that sort of 5-year span. VRE bloodstream infections on the right, and then at the bottom is your carbapenemase producing enterococci colonization and infections, both of which are going up. So concerning trends, right? We don't want to see that kind of stuff because that means more infections that are harder to treat and worse outcomes for patients. Potentially. So if we don't do anything about this, what does that mean? If we really don't come together and take action and try to make changes, what are we going to see? So if you think about that graph showing the 46% of deaths from infectious diseases, that's kind of what this is. So your infectious diseases is the orange line at the bottom, all causes at the top there, and then the non-infectious cases. So we've seen throughout the 20th century that infectious diseases causes has reduced right down to that 3%. If we don't do anything, what this means about antibiotic resistance and trying to be more appropriate with our antimicrobial use, we might start to see that line go back up, taking us back to the dark ages of medicine where we didn't have antibiotics to prevent basic infections, what are now basic infections that can be cleared easily. And that's just me playing with lines in PowerPoint, so you don't have to take my word for it. There are people who actually study this stuff. So some of you might be familiar with the report that came out of the UK in 2014, the review on antimicrobial resistance. And they did some fancy, calculations and stuff like that. And they estimated that by 2050, if we don't do anything about this, we will see more than 10 million deaths a year from antibiotic resistant infections. And of course, that's not shared equally across the world. Some people are going to pay for that in more lives than other places. And to put that in perspective, so currently, there are about 700,000 deaths a year around the world from AMR, antimicrobial resistant organisms. And there are about 8 million cancer deaths around the world in a year. So 10 million deaths a year would eclipse what we're currently seeing in terms of cancer deaths. And so to me, that's a scary statistic. That's something that we don't want. That's something where I don't want my kids to be in that world where all of a sudden organ transplants are a much more risky procedure, more risky than they currently are, but because we now have this risk of antibiotic resistant infections with people who are immunocompromised. Same deal with cancer treatments. Your routine surgeries and elective surgeries like hip replacements and other joint replacements all of a sudden carry this much higher risk of infections that can't be treated. And really taking us back to a time where sore throats could kill you, a strep throat infection, or a leisurely afternoon pruning roses in your garden and getting a nasty infection from a prick could kill you. And we don't want to go back to that. So the last thing I'll leave you with then, one of the big things that I've seen in the few years that I've been working in this world is that antibiotics are often viewed as these benign medications. I'll just throw it on just in case. They might not actually have pneumonia, but we'll just give an antibiotic just in case. And one of the most important things, and I think you'll hear this a couple times today, is antibiotics are not benign medications. So we need to understand that these things are like any other medication. They come with side effects and risks. And so particularly if your patient is not going to see a benefit from an antibiotic treatment, if it's a patient with a viral illness, for example, then all you're doing when giving them an antibiotic is exposing them to potential harms. And there are a lot, depending on the antibiotic. As we've just talked about, development of antibiotic resistance, which could be as small as a number needed to harm of 1. So every time you give an antibiotic, that is exposing a patient to a potential development of antibiotic resistance. There are common side effects, which most people are probably aware of: vomiting, nausea, diarrhea, blah, 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 blah. 1 in 10 people will experience these. It's one of the most common reasons that people come to emergency room with drug-related side effects is from antibiotics. Allergic reactions, 1 in 15 people will experience those. Light sensitivity from tetracyclines. This one's one of my favorites from just a couple of years ago. I think they updated the adverse effects for fluoroquinolones to include there was severe aches, pains, heart problems, but it was aortic aneurysms and dissection were added to that, which is a pretty freaking severe consequence, especially if it's an antibiotic that's not needed or it's being prescribed for longer than necessary, those kinds of things. Kidney damage from vancomycin is well known. Drug interactions. I'm going to talk about older individuals, but when you have people who have more and more medications, throwing an antibiotic on there is more opportunity for drug interactions that we need to consider. C. difficile infection, pretty self-explanatory. This one is just from a recent presentation at one of these international conferences for bowel care or something or other. But they were looking at inflammatory bowel disease in elderly patients. So it was this Danish study, I think, where they have one integrated EMR, imagine that, that they were able to get all of this information from their group of patients. And they looked at people between 60 and 90, and they found that for those folks, there was an increased risk of developing IBD with every antibiotic course they were given, starting with 1, which took them to a 27% increase in developing IBD, to 2 courses, to 3 courses, to 4 courses. By the time you get to people that have 5 courses of antibiotics in that elderly age group, they were 2.4 times more likely to develop IBD. So again, not benign medications. There are consequences and potential bad effects from these things. So my plea to all the clinicians is to choose wisely. And choosing wisely as an organization is something that I think Mel's going to touch on, but that's a great place to go to for tips and hints on how to prescribe appropriately in many different settings. But really this works for every area of medicine, but making sure that we're using these things wisely, using our antibiotics wisely, because we want this global resource to last as long as it possibly can, so that future generations can have access to this, and we aren't getting to a point where some of our basic, what are considered now basic medical procedures, are at risk of becoming more and more dangerous due to antibiotic resistance. So, I think I made it through in a half hour. Perfect. That's my spiel. If you have any questions for me, you can reach me at the antimicrobial.stewardship. But now I'm going to pass it off to the clinicians, Mel and Stephen, and they will take you through some things that I'm sure will have more questions than I can answer. So let me bring you up here, Mel. This one. There you go.
Yeah.
Yeah.
Okay, thank you, Jay. That was a really good presentation. They're always a tough act to follow. I find like your presentations are a lot more interesting and entertaining. I think mine and Stephen's presentation is going to be a little bit didactic, but hopefully you find it equally interesting and entertaining as well. So my name is Melissa Kusi. I'm the antimicrobial stewardship pharmacist, as well as the infectious disease pharmacist for Regina. We also have Dr. Stephen Lee. He's our infectious disease physician in Regina. He was supposed to be here in person, but things came up and he wasn't able to make it. So we do have him joining via WebEx, and I'll let him introduce himself in a little bit. So first of all, I want to say thank you very much for inviting us here. Thank you to Tanya and Marcy and Kelsey. They had reached out to us and basically asked if we would be interested in coming and meeting with some of the clinicians and doing a presentation on antimicrobial stewardship, because sometimes we see some variations in practice. And so they had asked, can we maybe sit down and talk to everybody about antimicrobial stewardship, remind everyone how important it is, and kind of go over some of the common infections that we see, maybe talk about, most recent guidelines and what some of the recent evidence and literature is suggesting on how we appropriately treat our patients. So I think before I actually get into the presentation, I want to show everybody this slide, because it was actually absolutely perfect timing, because as I was preparing for my presentation this morning, I was getting panic texts from the ICU pharmacist and the infectious disease physician on call, and this is what showed up on my phone. And basically this is a patient that we have in the ICU with respiratory failure who grew an Acinetobacter, and this was the susceptibility report that came out. And so they're texting me, panicking, being like, what do we do? And as a clinician, if this doesn't give you nightmares, I don't know what will. Like, I looked at this and I was instantly terrified. I've actually never come across this before. But at the same time, I got excited because I was like, oh my gosh, this is perfect timing. I can talk about this in my presentation. And this just highlights how important antimicrobial stewardship is, because I think we can all agree that no one ever wants to be in this situation, because we are now going to be left with using options I actually haven't had to use in my clinical practice before. So I think this hits home that, antibiotic resistance, it exists, it's a thing. We're seeing it now in our prairies, clearly, like we just saw a case of it this morning. And so this is terrifying, and we need to start doing something about that now so we can prevent situations like this from happening. So I guess before I continue on with the presentation, I would like to first acknowledge that we are gathering here today on treaties 2, 4, 5, 6, 8, and 10 territory in the homeland of the Métis, and recognizing this history is important to our future and our efforts to close the gap in health outcomes between our Indigenous and non-Indigenous populations. And I would like to pay my respects to the traditional caretakers of this land. And reminding everybody the vision and the values of SHA. So we're wanting to promote healthy people, healthy Saskatchewan, and this presentation today is very much a collaborative effort of all of us coming together, talking about antimicrobial stewardship, creating awareness, and talking about ways that we can improve our practices to provide better patient outcomes. So as far as disclosures, I have none to report. For the outline, we'll have Stephen go over pneumonia. I'll talk about urinary tract infections, some skin and soft tissue infections, and then Staph aureus bacteremia. So that's what you can expect moving forward. And I will now let Stephen take over and introduce himself, and he will talk about pneumonia.
Yeah, so hi, my name is Stephen Lee. I'm one of the infectious disease clinicians in Regina. I'm so sorry I was supposed to come in person today, but just some personal things came up and I couldn't make it. So yeah, I'm here to chat to you guys about pneumonia. And again, tough act to follow from Jason, but maybe next slide. So I guess pneumonia, there's three different types that they kind of separate things into. There's community-acquired pneumonias, hospital-acquired pneumonias, and ventilator-associated pneumonias. And so the cutoff, basically is about 48 hours. And the reason why it's 48 hours after admission to hospital or ventilation is the thought that if there's a bacteria that happened with less than 48 hours, it's probably something that was acquired in the community rather than in the hospital or on a ventilator. So in terms of the microbiology, it gets pretty complicated, but the most common community-acquired pneumonia presentation is strep pneumo. So if you look at, and I'll talk about different empiric antibiotic choices in a second here, but basically if you look at all the empiric antibiotic choices, they all try and cover strep pneumo to an extent because strep pneumo is by far the most common cause of pneumonia. But it's important to kind of think about different pathogens in different contexts. So in hospitals, is the patient a risk for MRSA or Pseudomonas, etc.? And the biggest thing is also from a stewardship standpoint, don't forget about your differential diagnosis. So not everybody walks in with shortness of breath. Is it bacterial pneumonia? Sometimes it's congestive heart failure, in 2020 to 2022. Sometimes it's a viral infection, and maybe more often it's a viral infection nowadays. Atelectasis or COPD, etc. So next slide. So yeah, so I guess kind of going through the different syndromes here. The first one is community-acquired pneumonia. So if you look here on the right-hand side, I've kind of shown a table from the IDSA or the American Thoracic Society guidelines. It gets really complicated, and it's funny because I was reviewing all of this stuff because you don't think about it on a day-to-day basis. But when I looked at this, I'm like, wow, they made community-acquired pneumonia really, really complicated. I've never thought about this in depth. But long story short, it's trying to really get you to think about what organisms are you worried about. Now, the standard regimen that they kind of recommend is a beta-lactam with a macrolide or a respiratory fluoroquinolone. So in the Canadian context, because these are really American guidelines, most often you're going to see people, at least as an inpatient, on ceftriaxone azithromycin or on levofloxacin. And more often, I think in the Canadian context, at least in Regina, we use ceftriaxone azithromycin. So in terms of durations of antibiotics, usually the IDSA recommends 5 days for most patients. And, if you look at, I'm just going to tell them, I'll call them back here. So long story short, so five days for most patients, just because when they do studies in terms of how long patients need antibiotics for, they've kind of stayed down to 5 days. And actually there's more and more studies going to even shorter durations of 3 days. For MRSA Pseudomonas, they do recommend 7 days. That's probably just a factor of the fact that the studies haven't been done for those specific organisms yet. And a lot of times, as you guys probably know, cultures actually don't grow out for community-acquired pneumonias. And sometimes you're left to kind of choose some empiric options for antibiotics. And here they have all these different lines here, but that's really just making you think about ceftriaxone azithromycin or levofloxacin might be right in most cases, but let's say you have a patient who's from the community, but in the past week or two, or the past few months, they've grown MRSA from the sputum. So certainly that's a case where you might want to empirically add on MRSA, or if it's a patient who has cystic fibrosis and you've grown Pseudomonas in the past, certainly you want to cover Pseudomonas. So kind of just telling almost like common sense things where you let the clinical picture guide you. Next slide. So what to do after. So this is kind of your empiric choice, ceftriaxone azithromycin. But another thing to think about is what you do after you get cultures back. So certainly you want to de-escalate, so you can narrow based on sputum cultures. And, you know, narrowing is one thing, but if they're not improving after 40 to 72 hours, you might want to reevaluate, broaden antibiotics, figure out why they're not improving. And, you know, oftentimes, I mean, the IDSA doesn't specifically mention this, but, you know, obviously, if they're improving a lot, you can also consider narrowing or changing to oral options. And in terms of a big kind of, I guess, controversy is what to do with x-rays. So if you actually look at the guidelines nowadays, the IDSA and the American Thoracic Society do not recommend routine follow-up x-rays. And, you know, I don't know about you guys, but certainly as a med student, I was taught to review x-rays. But it's important to think about why that's the case. So the x-rays are not actually useful to review pneumonia. So there's no role of getting x-rays when you're trying to follow up a pneumonia, unless they're worse and you're suspecting an empyema and effusion. But to routinely follow up with x-rays and pneumonia is actually not indicated. It's not very useful because x-rays actually lag behind in their presentation. So lots of times, basically, after an episode of pneumonia, like, you might have improved clinically, but your x-ray still takes more time to improve. The real reason when I was taught as a med student, and the reason to consider repeat imaging, unless the patient's worsened, is actually to rule out underlying abnormalities. So if you have a large consolidation, you know, how much of, like, you know, for instance, maybe there's a cancer underlying that. And that's the reason why they recommend x-rays in the past, is just to make sure that isn't the case. But when a patient's improving, there's actually no role from an infectious disease standpoint to repeat imaging. And then certainly, you know, the rationale for doing repeat imaging depends on your individual case. And that usually is like many weeks later to make sure there's no malignancy. And, you know, that's kind of a patient-to-patient decision and, you know, beyond the scope of infectious diseases. Next slide. Hospital-acquired pneumonia is another entity. So what the IDSA actually recommends is to go by local biograms. So actually, Saskatchewan, we're very lucky with a very good microbiology team and stewardship team that actually a lot of centers actually have local antibiograms. So there, which is probably too tiny for you guys to read, is the Yorkton antibiogram, but I also included a QR code, which I figured out how to make QR codes during this COVID-19 pandemic. So, you know, that was a lesson learned during the pandemic. But if you look at that QR code, that's a link to your guys' antibiogram. So basically, the IDSA recommends you kind of tailor your antibiotic choice based on your antibiogram. But in general, I mean, if you look at it and look at your antibiogram, the agents that in Canada we usually use for hospital-acquired pneumonias is piperacillin and tazobactam as one option, but 3.375 grams IV Q6H in normal renal function if no Pseudomonas, and then just remembering that you need to do Pseudomonas dosing if you're worried about Pseudomonas specifically. And usually the IDSA recommends about a 7-day duration for pneumonias. But also remember to de-escalate based on your cultures, and you can actually even de-escalate if the patient's improving, even without cultures positive. And examples of that are, if your culture never grew MRSA and Pseudomonas, you can consider stopping the coverage for those specifically, if you had included it to begin with. Next slide. So hospital-acquired pneumonia gets a little more complicated, and you have to consider your specific pathogens that you're worried about. So the two ones that kind of are that affect your antibiotic choices are Staph aureus. So you want to consider MRSA coverage in high-risk scenarios. So the IDSA defines that as a unit where the methicillin-resistant Staph aureus rate is over 20%, or it's unknown. Now, it's hard to interpret that in a Canadian context because in general, our MRSA rates in Canada are lower than the US. Although that may be a little bit different because I find that Saskatchewan actually has a lot of MRSA. There's a study in 2014 where they showed a nasal PCR can have a very little positive predictive value. So you can't, like, it doesn't mean that because it's positive, that's what's going on here, but it's a high negative predictive value when you have a low pretest probability. So that sounds like a lot of like very complicated language, but that just means that if you don't think this is MRSA, like your community has a very low rate of MRSA, and the patient has a negative nasal swab, that means it's very unlikely for this to be MRSA, and then maybe you don't need to include coverage for that. So this is kind of a specific thing to discuss, and maybe very good to present to the stewardship team here, because the Yorkton stewardship team can kind of think about what their rates of MRSA is and what would make sense in their context. I would say as a clinician myself, if the patient's not very sick, like they're on an inpatient medicine unit, I don't routinely add MRSA coverage, even though I'm not sure we in Regina have specific MRSA reporting all the time. But, I find that in Canada, our rates are a little bit lower than the US. And so me as a clinician, I don't routinely do this. If a patient's super sick, like in the intensive care, or they're on antibiotics and they worsen, I do add vancomycin. So Pseudomonas is another, and that's not necessarily to say I do the right thing or wrong thing. I mean, this is just what I do, but certainly something for the team in Yorkton and the stewardship team to kind of discuss and think about. Pseudomonas, so it's kind of interesting as well. So this is kind of a common cause of hospital-acquired pneumonias. In Saskatchewan, I find we don't get as much gram negatives, but the US guidelines kind of talk about this. So patients should be started on an agent with empiric activity against Pseudomonas and Staph aureus. So that's why they recommend piptazo. Cefepime isn't commonly used in Canada. Levofloxacin, which at 750 does cover Pseudomonas. Imipenem, which isn't really available in the Saskatchewan Health Authority, or Miropenem, which is available with us. But at patients with very high risk of resistance or high risk for mortality, they actually recommend 2 anti-pseudomonal agents. Now that specifically refers to people who have had lots of antibiotic use in the past, or have high risk of mortality, such as cystic fibrosis or other lung conditions. Now, this is what the IDSA recommends. I would say that in the Canadian context, in the Saskatchewan specific context, we're lucky because gram negatives like the one that Mel showed you are actually fairly rare. So I think I practiced and trained in Ontario and Alberta, and in Ontario where I did my infectious disease training and I practiced for a year, we routinely saw Acinetobacters like Mel showed you. And so we would see Pseudomonas where the cultures would come back and everything was resistant, or we'd see other gram negatives like E. coli, everything was negative, or they were carbapenem resistant, and you'd have to call pharmacy to release stuff like azotrionam and colistin and other agents like that. So, this is kind of something to be interpreted on the local context. I feel like in Saskatchewan, I personally do not routinely use 2 anti-pseudomonal agents just because our antibiograms don't show that. We have very, very rarely seen pan-resistant gram negatives, and I guess we're fortunate for that. So this is why I guess the IDSA talks a little bit about your local antibiograms, and something certainly for a great talk for the stewardship team here, because something for you guys to decide what your guys' local protocol should be. But in Regina, I would say, I don't know if Mel can correct me if any of the other ID docs do something different, but I do generally start someone with pseudomonal coverage, but I don't routinely do dual coverage unless it's a patient who, even if they've had past antibiotic use, unless it's a patient who had specific resistant gram negatives in past cultures, or cystic fibrosis, or a patient who might be neutropenic, or chemotherapy and is immunosuppressed. I don't know if the other ID docs use something different, but I generally don't.
I'd say that they probably follow that same pattern too. I think the only time that I've maybe seen dual Pseudomonas coverage is like in our ICU population, where they've actually maybe grown Pseudomonas on previous cultures, and obviously they're in the ICU and critically ill. And so in that case, we would empirically use maybe 2 agents to cover Pseudomonas, but very rarely, in the vast majority of our cases, do we double cover for Pseudomonas.
Yeah, and certainly not, as the IDSA guidelines say, not wrong to do that, but certainly I think in Saskatchewan we're fortunate that we haven't gotten there yet. And so if we preserve these antibiotics, then maybe we will never get there, but who knows. And one thing to note is that, when you look at these guidelines, all of this is basically very limited evidence and very weak recommendations. So, that's why, sometimes it's okay. Like for us, we don't necessarily do that. It's because the IDSA hasn't even said that this is we have all this evidence that you must do this. This is kind of what they've seen in America and what they kind of make the guidelines for. So, but there's very little confidence in that. And a local context is important. Next slide. So key stewardship points before, I think I've rambled on a little bit here. So, not all shortness of breath is bacterial pneumonia. Think about other things like CHF, viral pneumonias, et cetera, et cetera. Sputum cultures by themselves don't mean there's infection. So there's more and more literature to show that the lung actually has its own microbiome. So certainly sputum cultures can contaminate from stuff from the mouth. And, obviously there's certainly a lot of normal bacteria in the mouth, but even within the lungs, there's healthy bacteria. So pneumonia is a clinical diagnosis combined with the microbiology diagnosis. So just because they cough something up and it grows doesn't mean it's pneumonia. Evolving evidence for shorter course of antibiotics are good for most patients. So, the whole teaching about previously 14 days, it's getting shorter and shorter. And, sometimes I've been tempted to put people on 3 days of antibiotics and stop it as well. Don't forget to narrow antibiotics. And, one thing in the COVID-19 era is that COVID-19 bacterial infections are relatively rare. A study was done where 71.9% of patients got antibiotics, but only 6.9% were diagnosed with bacterial pneumonia. So let your assessment guide the use of antibiotics. And cases where there might be a bacterial co-infection include when there's consolidations or a patient worsens after a period of improvement. So that's it for rambling on about pneumonias, and I'm going to turn things over to Mel.
So I guess before we quickly move on, do we have any questions for Dr. Lee specifically related to pneumonia? Okay. If you think of anything, you can feel free to type in at the end of the presentation. So thank you, Stephen. So I'll carry on with the rest of the presentation, and if at any point, I need to be corrected, Stephen, please jump in and provide some clarification or correct me. So we're going to talk about urinary tract infections to start off with. And this is a very broad topic, so I kind of had to think about what areas that I wanted to focus on for the sake of time. And so we're going to talk about asymptomatic bacteriuria, acute uncomplicated cystitis, and acute complicated urinary tract infections, including pyelonephritis. So before we actually start talking about an infection, a urinary tract infection, I want to talk about asymptomatic bacteriuria because we see a lot of treatment of asymptomatic bacteriuria unnecessarily or inappropriately in Regina. And I imagine if it's a problem in Regina, it's probably a problem here and probably a problem everywhere. And so I wanted to draw attention to it and talk about it because it is a very important topic. So what is it? It's essentially the isolation of bacteria in an appropriately collected urine sample in a patient without any symptoms of a urinary tract infection. So these are patients, they're not complaining of dysuria, they don't have any urinary frequency or urgency, no suprapubic pain, no fevers with cystitis symptoms, no flank pain, no CVA tenderness, no specific urinary tract symptoms related to it. They just have bacteria hanging out in their bladder. Another thing that we'll commonly see with ASB is pyuria. So pyuria and asymptomatic bacteriuria does not mean there's an infection present. And we'll kind of get into it, but the diagnosis of a UTI is very much a clinical diagnosis. So pyuria is very common, and white blood cells present in the urine along with bacteria does not mean that there's an infection there necessarily if the patient is asymptomatic. So as I said, pyuria is common in ASB. It's not an indication to treat. There was one study that showed that the prevalence of pyuria in patients with diabetes and asymptomatic bacteria was almost 80%. It just shows, how common we can see it. So when should we be collecting a urine culture? So Choosing Wisely Canada is kind of our national voice for reducing, I think Pat Robinson had a comment, we'll get to that comment later, sorry. So Choosing Wisely Canada is our national voice for reducing inappropriate medical tests or treatments. And so they provide some recommendations on when we should actually be ordering urine cultures. And what they recommend is that we really shouldn't be ordering a urine culture unless minimum criteria for a urinary tract infection are present. And they base this off of the modified Loeb criteria. And so what they're recommending is in a non-catheterized resident, the minimum criteria where we should be ordering a urine culture is someone who has acute dysuria or two of the more of the following. So they've got a fever with a new or worsening urgency or frequency, suprapubic pain, gross hematuria, flank pain, urinary incontinence, etc. And so just noting that confusion alone or confusion in isolation is not a symptom of a urinary tract infection in a non-catheterized resident, and really shouldn't be the sole symptom prompting that urine culture. It's a little bit different in a catheterized resident because these patients aren't necessarily going to be exhibiting kind of the common cystitis symptoms, so they likely won't be experiencing acute dysuria or frequency or urgency. So that criteria is a little bit different, but we're not going to get into what that criteria looks like. We're going to focus on non-catheterized patients for this presentation. And so there are certain indications where it is appropriate to actually screen for and treat ASB. And so the 2019 IDSA has guidelines on the management of asymptomatic bacteria, and they recommend that it is completely appropriate to be ordering urine cultures and screening for ASB in patients who are pregnant or in patients undergoing invasive urologic procedure in which mucosal bleeding is anticipated. Also for renal transplant patients, some experts will screen for ASB and treat ASB within the first few months following a transplant. And I think the evidence is probably strongest within that first month post-transplant. So certainly in that population, it's completely appropriate to be, screening and treating ASB. Studies that have not demonstrated benefit in treating ASB have been shown, there's no benefit in screening for and treating ASB in non-pregnant women or in diabetic women, no benefit in elderly or long-term care residents or spinal cord injuries or catheterized patients. And so we don't recommend screening or treating for those patients. And so as I kind of mentioned before, we see a lot of ASB and a lot of treatment for ASB in Regina. And recently we went back and we had some students do a retrospective chart review to see how many patients were actually being treated for an ASB. And Jason and the students kind of did all the work, so I can't take any credit for that. But we had students review 200 charts in our emergency rooms from both Pasqua and Regina General Hospitals. And they looked at patients who had a positive urine culture. And they excluded any patients with catheters, urinary stents, anyone who was under 18, or any pregnant women. And so they looked at kind of the more straightforward patient population. And they used the McGeer criteria to differentiate a urinary tract infection from an asymptomatic bacteria. The McGeer criteria is used more for surveillance purposes. So it's used to kind of retrospectively go back and define urinary tract infection versus ASB. And so that's the criteria on the left. And so basically these patients had to be symptomatic, show specifically urinary tract symptoms, and have a positive urine culture to be considered having a urinary tract infection. And what they found was that about half of the urine cultures were deemed inappropriate. So we didn't really need to order a urine culture in about half of our patients to begin with. And about half of those patients were found to have asymptomatic bacteria. And 61% of those patients with asymptomatic bacteria received an antibiotic unnecessarily. So these were patients who, didn't present with acute dysuria, frequency, urgency, the suprapubic pain, likely came in with maybe more general symptoms of, fatigue or maybe some confusion or that sort of thing. And we weren't really sure what was going on, so we ordered a urine culture, happened to find bacteria and must be a UTI, and so we started them on an antibiotic. And just of note, 84% of the patients who were treated with an antibiotic had a positive urinalysis as the documented diagnostic criteria. So that was kind of no other symptoms were documented, but they had a positive UA, and that was kind of the driving force behind prescribing the antibiotics. So the most common non-UTI symptom documented was a positive UA followed by a change in mental status. And Jason had brought this forward to the eMERGE docs, and what we kind of decided on, it's like if nothing was documented, if no urinary symptoms were documented, if it's not documented, it didn't happen. So very likely, these patients didn't have any urinary tract symptoms and probably just had a positive UA that was driving these antibiotics. And so this quote was something that I pulled from an EMR actually last week. I was reviewing a patient, and I was reading a physician note, and they had said, on questioning, patient denied fever, vomiting, and dysuria. However, the urinalysis is abnormal and seems to be infected. So that's just kind of going back to the point of pyuria doesn't necessarily mean infection is present. There's lots of things that can cause pyuria, infection being one of them, but it's not the only thing that can cause that, right? And so making sure that we're tying it back to the patient and only treating if they're actually symptomatic, right? So why do we care about this so much? Well, we know that, as Jason kind of alluded to, antibiotics are not benign, and there's lots of adverse effects associated with antibiotics. There was a meta-analysis of 9 trials looking at the treatment for asymptomatic bacteria, and they found that patients who got antibiotics inappropriately, those antibiotics increased the incidence of any adverse event significantly, so the relative risk of being 3.77, and that was a statistically significant finding. The other reason why this matters and why we're concerned about it is because it contributes, every time we use an antibiotic, whether appropriate or inappropriate, it contributes to antibiotic resistance. And there was one study that looked at the treatment of ASB, and they found that in treating ASB, that was associated with higher rates of resistance to clavulin, to Septra. Sorry, I keep getting these questions that pop up. Which we can kind of get to later. Sorry, so this study had found that there was, in treatment of ASB, that was associated with higher rates of resistance to clavulin, to Septra, and to ciprofloxacin among subsequent E. coli urinary isolates. So we were using antibiotics to treat ASB. We were contributing to resistance on subsequent urinary isolates. And so you're kind of setting up the patient for failure in a sense, because it's like when they actually do present with an infection, we now have less than ideal options to treat them with because we've created this resistance now. There's also this new concept that asymptomatic bacterial colonization can protect against superinfections with more virulent strains. So that when we do send a urine culture and we find an E. coli growing in our urine, and it's not causing any problems, it's not causing an infection, it's not causing any symptoms or discomfort for the patient, that E. coli is actually protective in a way because it's preventing other organisms like a Pseudomonas from coming in and making a home in that bladder and maybe causing an infection. So it can actually be protective for the patient. There's also some evidence that shows that maybe treating asymptomatic bacteria could also increase the risk of subsequent UTIs. So I think there was maybe this thought that if we find bacteria in the urine, that we should be treating it so it doesn't turn into an infection and doesn't cause patient harm. But actually what some new evidence is showing is that treating that asymptomatic bacteria actually could increase the risk of subsequent UTIs. And so we're not preventing urinary tract infections, we could actually be contributing to them and causing them. So in summary, pyuria is very common in asymptomatic bacteria. It's not an indication to treat. The patient is not symptomatic. Only order a urine culture if the patient is actually symptomatic of a urinary tract infection. Confusion alone is not a symptom of a urinary tract infection in a non-catheterized patient. And so don't go looking for bacteria, don't go looking for something, because if there's a good chance you're gonna find it. And when you do, it's very hard to ignore that result once you do grow something. Screening and treatment of ASB is only recommended in pregnancy and in patients undergoing invasive urological procedures, and it's certainly reasonable in renal transplant patients within the first month of transplant. And reminding us all that antibiotics are not benign, and they do contribute to adverse effects and antibiotic resistance. So moving on, we're going to talk about acute uncomplicated cystitis and acute complicated, including pyelonephritis. So just to kind of go over some definitions quickly. So cystitis, just reminding us, is inflammation or infection confined to the bladder or the lower urinary tract. A pyelonephritis is inflammation or infection of the kidneys or upper urinary tract. Uncomplicated just refers to infection in an otherwise structurally or neurologically normal urinary tract. And complicated refers to an infection in a urinary tract with functional or either structural abnormalities, such as an anatomic abnormality, like if they have a fistula present, maybe an iatrogenic abnormality, if they have an indwelling catheter or a urinary stent, if they have a voiding dysfunction, like in neurologic disease, or if they have a urinary tract obstruction, like is the case with kidney stones, for example. And sometimes we consider certain populations to be complicated, like pregnancy or diabetics, for example. I would say that we consider diabetics to be complicated, more so if it's a poorly controlled diabetic. If it's someone who's, you know, within their A1C requirements, they don't really have any long-term complications of the diabetes, we don't necessarily need to consider them complicated. Males too, we've typically, I think historically, considered them to be a complicated urinary tract infection, mostly because of the anatomy. But I would say that if you have a male who is presenting with symptoms of cystitis, and it's very obvious, or it appears to be obvious, that it's maybe the infection is localized to the bladder, and there's no signs that the infection extends beyond the bladder. And like I said, otherwise healthy male, we don't necessarily need to treat him as complicated. And our immunosuppressed patients and our CKD patients, we tend to treat as a complicated picture and likely would require a little bit longer duration. So the way my brain works is I kind of like to think about pathophysiology and understand the microbiology, because then I can tie it back to my antibiotics and I can rationalize why we use some of the antibiotics we use. And I can understand how the infection developed. And so it makes sense in my mind that way. So as I said, cystitis is an infection of the bladder. Pyelonephritis is an infection of the kidneys. And the infection tends to be very much an ascending pathway. So bacteria travel through the urethra into the bladder, infect the bladder, and then they can extend beyond that into the kidneys and infect the kidneys. So as I said, this is predominantly an ascending pathway, most often caused by gram-negative bacilli. In some cases, it can be a descending pathway via hematogenous spreading. So in cases like where the patient's bacteremic, for example, patients where the sorry, I keep getting these questions that pop up. So in cases where the patient is bacteremic, for example, a Staph aureus bacteremia, you can get kind of a descending pathway, and you can get that seeding from the blood into the kidneys to cause infection that way. Okay, thought someone was going to be asking a question. And so what I'll say about this is, because it's predominantly an ascending pathway, and in rare cases, you know, it's maybe more of a descending pathway, such as the case with Staph aureus usually. If we find Staph aureus in the urine, that really should be our prompt that this could be a descending pathway, and we really should be doing a blood culture to rule out a bacteremia. So understanding the process kind of helps, like I said, rationalize the investigations that we conduct and then the antibiotics that we use. So what are the organisms that are causing our urinary tract infections? Well, the vast majority of time, this is a monomicrobial infection. So more than 95% of the episodes are caused by a single bacteria. And E. coli is by far the most common cause of urinary tract infections. In different settings or in different host factors, we might isolate some other organisms. But as I said, E. coli is for sure the predominant one. So in our young sexually active female population, we might sometimes isolate Staph saprophyticus. In our long-term care facility or hospitalized patients or patients with recurrent UTIs, we might see some more gram-negative bacteria, maybe some Enterococcus, Pseudomonas, that sort of thing. So for an acute uncomplicated cystitis, you know, what are the main symptoms? How do these patients present? How do we diagnose this? So usually for acute uncomplicated, the classic symptoms of cystitis are dysuria, increased urinary frequency, urinary urgency, plus or minus suprapubic pain, and gross hematuria. So this excludes fevers or any other signs or symptoms that the infection extends beyond the bladder. So if the patient is exhibiting chills or significant fatigue, and they're febrile, this is more of an indication that the infection is beyond the bladder, and this is a more complicated picture. If the patient's having flank pain or CVA tenderness, you know, these are all indications that this is beyond the bladder. So as I said, the diagnosis is very much a clinical diagnosis based on the classic signs and symptoms. And then in those cases, particularly if this is like a first presentation, you don't always need to do a urinalysis and send off a urine culture, mostly for outpatients. And like I said, if it was a first episode, I think most of us will probably be dealing with inpatients, and so in that case, it's certainly reasonable and appropriate to be sending off a urinalysis and a urine culture to know that what we're dealing with, especially because we are worried about resistance rates with our E. coli. So for our atypical urinary symptoms, the diagnosis is then supported by the presence of pyuria along with bacteria on the UA or the culture. I will note that the absence of pyuria almost always excludes a UTI. And so if it's not there, then you should be looking at a differential diagnosis because it should be there in the vast majority of cases. The other thing I'll just quickly comment on for a urinalysis is if under the microscopy portion, if they note that white cell casts are present in the urine, this could be more indicative of an upper tract infection rather than just simple cystitis. So what does the treatment look like? So first, we should be ruling out pregnancy in women because that'll change the antibiotic that we're going to be using. So if you look at different references, it'll say, you know, first line options, appropriate options would be things like macrobid, Septra, trimethoprim, fosfomycin. But I would say it's, as Stephen kind of alluded to, it is very important to know your local susceptibility patterns and look at your local antibiograms. And so in Regina, for whatever reason, Yorkton didn't have susceptibility patterns associated for macrobid. But so in Regina, we know that our E. coli susceptibility for macrobid is 97% for all isolates. So macrobid will cover E. coli the vast majority of cases for E. coli. Septra, on the other hand, here in Yorkton, for all isolates, our E. coli susceptibility for Septra is about 79% for all isolates. So not as great as maybe macrobid if you're comparing it to Regina data. Trimethoprim will probably have similar resistance rates, and you might consider using trimethoprim if a patient has a sulfa allergy, for example. So that could be a case where you would be looking at using it. We don't use it that often, truthfully. Fosfomycin is a one-time dose, and while it's probably tempting to use because it's a one-time dose, and it technically is considered a first-line option in lots of different references, I would strongly urge you not to use it as a first-line option because it is more broad spectrum. It does cover things like Enterococcus and Pseudomonas and ESBLs, so we really should be reserving fosfomycin for those more resistant organisms and not be using it right off the hop. So I would say that probably our first-line option here is macrobid, and that's a 5-day treatment duration. We don't need to go beyond that. For Septra, we're looking at a 3-day treatment duration. And once again, don't really need to go beyond that for an acute uncomplicated. Other regimens that we could consider, although they're definitely not first line, would be things like cephalexin. You might see that more for like pregnant women, for example, or clavulin or ciprofloxacin are some other options too. So moving on to acute complicated urinary tract infections, including pyelonephritis. So symptoms of an acute complicated UTI are basically symptoms of cystitis, so your dysuria, frequency, urgency, and fevers and systemic signs and symptoms. So chills, rigors, significant fatigue, flank pain, that sort of thing. Males with symptoms of pelvic pain or perineal pain may need to be further evaluated for acute prostatitis, and I'm not going to go into that because it wouldn't be appropriate for me to go into that. For pyelonephritis, typically what you'll see is maybe fevers, chills, flank pain, CVA tenderness, nausea, vomiting. Symptoms of cystitis aren't always present in a pyelonephritis, so just to be aware of that. When we're conducting our investigations and someone's presenting with an acute complicated picture, including pyelo, we should be sending off a urinalysis and urine culture and sensitivities, possibly blood cultures, if they're appearing septic. And so the diagnosis is clinical, supported with our findings. So patients who present with symptoms of acute complicated UTI with pyuria and bacteria supporting that diagnosis. Flank pain and CVA tenderness in the setting of pyuria and bacteria are suggestive of a pyelonephritis. And the absence of fever or typical cystitis symptoms don't necessarily rule out that diagnosis. Once again, an absence of pyuria almost always excludes a urinary tract infection. An exception to that would be in a case where we're suspecting a pyelonephritis and maybe there's a kidney stone kind of blocking a ureter and we're not getting that communication to the bladder, we might not see pyuria or bacteria on the UA or the urine culture. So I think that would be probably a rare case. So what does treatment look like for acute complicated, including pyelonephritis? So as I said, macrobid is usually a first-line option for acute uncomplicated because that's infection confined within the bladder. But macrobid and fosfomycin should not be used for acute uncomplicated or a pyelonephritis because they don't achieve adequate tissue levels outside of the bladder. So it would not be appropriate to use them. I put a question mark by fosfomycin because there is actually new evidence coming out showing that fosfomycin might actually be non-inferior to some of our other first-line options for a pyelonephritis and acute complicated urinary tract infections. I don't think the jury's out on that one yet, but there is some new data coming out showing that we might be able to use fosfomycin for these pylos. So just something to be aware of, that we might see that kind of in future recommendations. So empiric therapy really is going to depend on severity of illness, risk factors for resistant pathogens, specific host factors, and once again, your local resistance patterns. It's very important to know what those are. So just reminding us all. Is there a question? No, okay. So just reminding us all, here in Yorkton, our E. coli susceptibility for our inpatients for Septra is about 68%. For ciprofloxacin, it's about 80%. For ceftriaxone, it's about 94%. And so that's very important, because when we're thinking about empiric treatment for a patient presenting with a pyelonephritis, you would look at your guidelines and they would say, Ceftra or Cipro are appropriate first-line options. But if you knew what your local resistance patterns looks like, you would look at this and be like, oh my goodness, 1 out of 3 patients, if we put them on Septra, would not respond empirically. And so that's why it is so important to know what those resistance patterns look like. So your empiric therapy, you can get it correct off the hop so that you set yourself up for success. For inpatients, it's completely reasonable to start off with IV therapy for the first, 1 to 2 days. And then if they're clinically improving, then making sure that we're reassessing and then transitioning to oral. And then, by that time, hopefully we'll have our susceptibility report back and we'll be able to, maybe it might take a little bit longer than 1 to 2 days. But, hopefully after, 2 to 3 days, we're making sure we're reassessing and then stepping down to an appropriate oral option, assuming that the patient's responding. Of note, oral beta-lactams are less effective for acute complicated urinary tract infections, but they are appropriate if susceptibility is documented and other agents are not feasible. And in the case of an E. faecalis, for example, amoxicillin is actually the oral drug of choice in that situation. So your treatment can consist of many different options. And so if we're choosing a fluoroquinolone for a treatment, for example, you only need to treat for about 5 to 7 days. There's lots of evidence, or some good evidence, I'll say, that's coming out that, for example, there was a randomized control trial that came out that showed that a 5-day course of levofloxacin was non-inferior to a 10 to 14-day course for acute complicated urinary tract infections, including a pyelonephritis. So I think we used to think of a pyelonephritis in an automatic 2-week course, and there's a lot more data coming out showing we don't need to treat for that long. So for fluoroquinolones, as I said, you can get away with 5 to 7 days. For Septra, same thing. You don't need the full 2 weeks. You can get away with 7 to 10 days of Septra for an acute complicated urinary tract infection. When you start looking at your beta-lactams, that's kind of when you're looking at maybe a little bit of a longer treatment duration, because it is a time-dependent killing mechanism. And so you are looking at like kind of the 10 to 14-day treatment duration for a pyelonephritis or an acute complicated picture. And so I've highlighted ceftriaxone for you guys, thinking that that's probably a very reasonable first-line empiric option. Because of your local susceptibility patterns. As I showed for inpatients, your E. coli susceptibility for ceftriaxone was 94%, and that was a lot higher than what Septra and ciprofloxacin were. So if someone comes in with an acute complicated urinary tract infection or pyelonephritis, starting them on ceftriaxone empirically is probably pretty reasonable until we have our susceptibility reports back. And so total duration of therapy is anywhere from 5 to 14 days. Depending on their clinical response and depending on what agent we're using. And just a quick note that the duration of antibiotic therapy, it does not need to be extended in the setting of a bacteremia in the absence of other complicating factors. So if we have an E. coli pyelonephritis and they happen to be bacteremic as well too, and if we're very confident that that bacteremia was because of that urinary source and there's no other signs that there's infection anywhere else, we don't need to extend that duration of therapy just because we found it in the blood. If we put them on a fluoroquinolone and they're responding and they're clinically improving, we can treat them with a 7-day course, and we don't need to extend for another week just because they were bacteremic. There's no evidence to shows that the patients are going to have any further benefit from that. So I think I will quickly pause there. So it was a big topic, and I'll maybe throw it out to the audience and ask if there's any quick questions. Okay. Oh, maybe one.
I just had a question about, do you see prophylaxis anymore in your practice?
I usually wouldn't be involved in that, just because I'm more of a kind of consult basis, but Stephen might in his practice. So Stephen, do you see any prophylaxis in your practice?
Yeah, so sometimes you do. I mean, I prefer to use like a pill and pocket regimen instead of actually like doing like a pill and pocket regimen. So like basically whenever a patient starts having small amounts of symptoms, then they start on antibiotic rather than like chronic prophylaxis. Just because I find chronic prophylaxis, sometimes patients end up just getting like a resistant organism. And a lot of times I think a lot of those cases, I find, you know, UTI symptoms are really hard to tease out. And so I think for those cases, the big thing is, and pill pocket is very reasonable, but the big thing I think is, one, are there any reversible causes of UTIs? Like, you know, like they should see a urologist. Can a urologist, is there an anatomical abnormality? Is there a Foley catheter? Is there like a correlation to things such as like it's post-intercourse or something like that? So like there's certain lifestyle things or certain anatomical things that can be fixed to reduce that risk. So that's the first thing. And I find that a lot of times when you address that, it actually just addresses the recurrent UTI in general. Or the second thing is, I mean, you know, chronic pelvic pain is also like a very common syndrome, right? So just to make sure that, you know, this is truly a UTI symptom and not something else.
In the context of recurrent urinary tract infections, I sat in on a presentation like a couple weeks ago, actually, and they had a physician, an infectious disease physician, kind of talking about his treatment for recurrent urinary tract infections. And he was talking about, you know, how long do you treat for recurrent urinary tract infection? And he had brought up a patient that, you know, had very frequent recurrent urinary tract infections. And when she came to him, she had said, you know, my symptoms, I need a longer course of treatment because my symptoms typically last anywhere from 7 to 10 days. And so then he had kind of posed the question to the audience, you know, would you extend their treatment to a 7 to 10 day course because your patient is saying that she has symptoms, you know, for that long. And he actually found a study that talked about recurrent urinary tract infections. And in this study, what they found specifically for recurrent infections is that even after the infection was treated, on average, it took anywhere from like 7 to 21 days for symptoms to resolve. And that doesn't mean that you need to treat them with antibiotics for that long, but it's just knowing that that could sometimes be the case and then communicating that with your patient and setting that expectation that, look, we will treat this bacterial infection. You're only going to need like whatever it is, a 5 to 7 day course, but your symptoms will, you know, can often persist beyond that. And that doesn't mean that we need to extend the treatment duration. And so I think it's just kind of communicating those pieces of information to your patients are probably pretty important. So I just wanted to add that tidbit because I thought that was a very interesting learning point, at least for me. Are there any other questions?
Right. Well, first of all, I want to thank you for this wonderful presentation and for bringing this very important topic to Yorkton. In terms of antibiotics stewardship. My question is, I mean, I'll put my question towards an outpatient antibiotics stewardship because the bulk of the use of antibiotics happen in the outpatient. Yeah. Especially these days, and that we are using more of telemedicine. Okay, how do you differentiate a patient who is asymptomatic bacteria on the phone, especially when you are talking to a patient from nursing home, which you cannot even examine, and they are telling you that this patient has been sick and is feeling very weak. And then this is a patient that has a history of previous hospitalization for urinary tract infection. So how do we deal with that? Going by what Steve said, that we can use pill for pocket. And the bulk of this topic is more or less like antibiotics stewardship. Looking at the first, let me say, data that you presented as Justin, yeah, it was very scary that, I mean, if you start misusing antibiotics, the mortality rate at that time was close to 46%. And now we brought it down to 3%. So if you start using antibiotics for pocket, basically, that means we're not really abiding by the antibiotics as stewardship. And if you look at the current data, the number needed to treat for outpatient urinary tract infection is close to even way above 300. You need to put more than 300 patients on antibiotics to treat the real to be able to treat one patient that has a genuine urinary tract infection. So the issue of using a pill for pocket or treating a urinary tract infection, I'm not sure whether that will be okay, you know, or we have a better way of diagnosing a urinary tract infection, even in pneumonia, outpatient pneumonia. Is there any role of single antibiotics for outpatient pneumonia, or can we find an effective way of minimizing the use of antibiotics? Because that is the reason why I'm coming for this lecture, to find if there's other means we can minimize the use of antibiotics, if there are better way we can diagnose this disease in order to effectively treat this patient and reduce the use of antibiotics. That's my question. So rather than telling us the pathophysiology of urinary tract infection, giving us the duration of the antibiotic we can use, I find it to be more helpful to the clinicians. I mean, if there are other ways we can effectively diagnose the disease so that we can reduce the use of antibiotics.
Thank you very much for that perspective. Stephen, since you're the physician and you're the one who, you know, sees outpatients as well and does the diagnosis piece, can you add any insight to those comments?
Sorry, I just had a bit of difficulty hearing the question. Can you just repeat it really quickly, Mel?
Well, instead of me summarizing, are you able to just quickly summarize for...
My question is there a better way we can apply the use of antibiotics? So that, because the bulk of this topic is antibiotics as stewardship, right? Telling the clinician what we need to do to reduce the use of antibiotics. Right? Using antibiotics pure for pocket, I don't think it fits what we are here for. That's my question, basically.
Sorry, you might have to speak into the mic a bit more. I heard something about you want to reduce the use of antibiotics.
Yeah, so he's saying if the whole goal is to kind of reduce the use of antibiotics, what kind of tips or things are there available for clinicians to do that? And, you know, talking about sort of prophylactic use in terms of strict antimicrobial stewardship might still not be the best. So just from my own perspective, right off the bat, I think there is a spectrum here, right? Of like, it's not necessarily don't use any antibiotics at all, because obviously we have them and you need to treat patients that are. So it's finding those things where there are cases where, yeah, we pretty clearly a viral infection, we know it's not going to help. When you get into the world of, like you were talking about, virtual visits and stuff like that, and it's hard to get a clear clinical picture, or if the patient isn't able to verbalize that, or if you're just talking to maybe nurses at a care home or something like that, right? So it's about trying to get as much information as you can to make that diagnosis, and doing the best with what you've got, right? So clearly there are going to be a big gray area where it's like, it might be hard to say what the best decision was, because you don't have that sort of black and white, like it's clearly a viral illness and we can not prescribe for this. So that's where that clinical judgment piece comes in, and really trying to ensure that you're taking as much information in as possible. And certainly there are pieces like diagnostic tools and stuff like that, some of which we don't have available in Saskatchewan, right? I know we've often talked to people and they'll say, you know, if I just had a point of care CRP test or something that I could do in the office to help me diagnose whether this is a pneumonia or just a viral respiratory tract infection. So things like that can help guide some of that. But I think in the end, a lot of that stuff still comes down to a clinical diagnosis. So that that tool might help give some clarity, but it's just about oftentimes doing the best you can with what you've got available. I don't know if you want to add anything to that, then, Stephen, if that makes sense.
Yeah, so I should have specified before, prophylactic antibiotics, I answered the question about antibiotics. There are actually specific criteria you should, like, not every person with a UTI should have prophylactic antibiotics. This is, and I should have mentioned this earlier too, there are specific patients with specific criteria that would qualify for that. So a patient who comes with one UTI should not get prophylactic antibiotics. These are patients with, and I can't pull the exact number, there's guidelines to talk about this, but there's a specific guideline on how often it has to happen. So this is someone who, routinely is coming to hospital, routinely is getting UTI symptoms, and so frequent that it's basically ruined their quality of life. Those are the patients who should get a prophylactic antibiotics, not people in general.
Okay, does that kind of answer your question? Sorry. Yeah. I'm just kind of looking at the chat here quickly, just so I don't miss anything. So I think I'll maybe just skip to the urinary tract infection piece. So someone had just commented, urinary tract infection is extremely uncommon in young healthy males. Young healthy male presenting with lower urinary tract infection, I think about an STI, prostatitis, or a complicated UTI. Once the first two are excluded, I would look for anatomical abnormalities in the urinary tract and will treat the infection for at least 10 days, assuming that it is a complicated urinary tract infection. And someone had agreed with that comment, so thank you for those comments. Someone else had said, I've noticed that shorter duration of therapy is being prescribed for urinary tract infections using beta-lactam antibiotics. Is it necessary to finish the full 7 to 10 day treatment, given that the patient is clinically improving? Okay, so I think I'll answer that question first. So I'll say in general, what the evidence would suggest would be for beta-lactams, just thinking about how beta-lactams kill. It's a time-dependent killing process. And so what the evidence would suggest would be, around that 10-day mark is probably what we should be aiming for to treat the infection. This is probably going to be a very patient-by-patient case. If you have someone who has a complicated urinary tract infection, and they respond quite quickly on a beta-lactam, and initially you kind of had the 10 to 14 day course in mind, but they responded, by day 3. And it's like, at day 7 then, if their white blood cells are normal, if they've remained afebrile, if they're clinically stable, if they're no longer symptomatic, then yeah, in that case, I would be completely comfortable stopping after 7 days. I don't know if, Stephen, you want to add your perspective? Or even less, Yeah. Maybe you can get away with a little bit less, but.
I think, yeah, it really depends on clinical assessment. And if you look at guidelines for simple UTI, it's even shorter than that. So yeah, I think it really depends on that.
Another question, can you keep using the same antibiotic for simple cystitis that is recurrent? And so I would say to this, if we have the susceptibility, then yes. If it's empiric therapy and we go back and we look at what we look at what they've isolated in the past, kind of go off what those trends are. But also, like, if they've had an E. coli, on recent urinary isolates grow out, and they've had multiple courses of antibiotics and they're now presenting again, I think for empirically, I would at least probably use a different agent from the last one, just to be on the safe side of things. But I think, obviously, certainly once you have susceptibility reports out, then you can tailor as necessary. Stephen, would that be your approach as well?
Yeah, I think tailoring once you have, I think that I agree.
Okay.
Excuse me, for simple cystitis, we really don't use culture at all. We go by the history. You have frequency, dysuria, and female, we give you antibiotic. That's it. We don't even bother with UA. So I don't know if that practice is bad. Thanks.
Stephen, you'll be able to comment more than I will. I think in an outpatient setting, at least, from what the guidelines would suggest, what I've read. In acute uncomplicated cystitis, I'd say more so with like a first type of presentation, yeah, you don't always need to do a urinalysis and a urine culture. And also, you know, when we're using things like macrobid and we're pretty confident that we're going to be covering E. coli the vast majority of time, then yeah, you don't necessarily need to be worried about doing a urine culture and finding out what that susceptibility report is. Stephen, do you want to add to that?
No, I think I agree. Yep, I think that like very different context, inpatient and outpatient.
Yeah. Okay, these are good discussions. I hope we're answering all of your questions, and I hope you guys are taking learning pieces away from this. I do apologize because this is very much more of an inpatient-focused presentation, and so we weren't really sure, you know, what the expectation was from everybody attending, and so some of this is very much review for everybody. But it's good to know, you know, what you guys would like to see from upcoming presentations so we can maybe tailor accordingly moving forward. I think I hit a button here that I want to get rid of, and I don't know how to move to the next one. How do I?
Turn off the annotate. That should work.
Okay.
There. Make this go away.
Thank you. Okay, so we're going to move on and we're going to talk about skin and soft tissue infections. Once again, this is kind of a broad topic, and so I'm just going to focus on cellulitis and skin abscess. So once again, going over a brief definition, cellulitis is an infection of the deep layers of the skin caused by bacteria. So what are the bugs that are causing our cellulitis? So cellulitis, the vast majority of time, the bugs that are causing this are our beta hemolytic streptococci, particularly our group A strep organisms or our strep pyogenes. Staph aureus can be a cause, but it's definitely less common in our cellulitis. When we're dealing with things like a skin abscess or a purulent infection, you know, in those situations, most commonly a Staph aureus is the pathogen, and that can occur in up to 75% of the cases. And when I was rounding with some of one of the ID docs, she had said, you know, when you're going and we're doing our assessment for the cellulitis, she's like, when you see a cellulitis and you see more of a lateral spread, you know, think streptococcus. If you go and see a cellulitis and it's more of a vertical spread, think Staph aureus. And so that was kind of like a little tip or clinical pearl that I took with me and sharing with you guys. So manifestations, what does this look like? And so cellulitis is something that we see very often. It's a commonly occurring infection of the skin caused by bacteria, most often by streptococcus or group A strep and Staph aureus. So what happens is basically the surface of the skin acts as a protective barrier, and then when we have damage to that skin, that allows bacteria to kind of go into the tissues and then cause infection. And so what you can see then is often a patient presenting with a painful red rash that's, you know, there's maybe associated swelling and it's quite warm to touch. And as that infection progresses, you can see it maybe extending beyond the extremity, and then you can maybe see some blisters starting to form. The patient might be febrile or showing other systemic signs and symptoms. And then in some cases, you can kind of get enlargement of regional lymph nodes. And I remember one of my ID physicians saying, you know, usually if there's enlargement of the lymph nodes, that's more streptococcus, so think streptococcus. And Stephen, you can once again correct me if I'm wrong. And the majority of the time, cellulitis, it's almost always unilateral. And so once again, I'm not the expert in this situation, but there are different things that can manifest or mimic a cellulitis. And so if someone is presenting with what you suspect me to be maybe a bilateral cellulitis, then and maybe looking at your differential diagnoses, because it's very uncommon. And often when I'm rounding with the ID physicians, if they get a case of a bilateral cellulitis, they'll often chuckle and be like, no, it's not. It is something else. And it's just that it's so rare we don't see it. So think about something other than a cellulitis. It's kind of like candida pneumonia. You know, Dr. Lee will often say candida pneumonia doesn't exist. We treat it all the time, but it doesn't exist. And so bilateral cellulitis is one of those things where it's just very rare and it's, yeah, not common. So think about other things that could be causing that. And it's most often seen in our lower extremities. So what's the clinical approach to cellulitis? As I kind of alluded to, there could be multiple differential diagnoses, and I am not the expert in that, so I will not be going into what those are, but there's likely other investigations that you guys as physicians would need to conduct to kind of rule out other causes. And so cellulitis is very much a clinical diagnosis based on manifestations and patient history and then supportive laboratory findings. And once you kind of rule out other possible causes. Patients who have a drainable abscess should undergo incision and drainage, and we should be sending those samples for culture and sensitivity if we're planning on starting on antibiotics. So if you have a patient with a small abscess and not a lot of surrounding cellulitis, and they're systemically well, you know, often all you need to do is cut that open, drain it, irrigate it, and you don't always need to start them on antibiotics, right? So if we don't plan on starting them on antibiotics, we don't really need to be sending off a culture for that. But certainly if there is an abscess and there is surrounding cellulitis and they're systemically unwell, completely appropriate to be starting on antibiotics in addition to that source control, and then sending that off for culture and sensitivity. So I'll say for the most part and for the vast majority of our patients, the duration of therapy for a cellulitis is 5 to 7 days. In some cases, you can maybe extend beyond that, and that would be for more severe, complicated presentations. But the vast majority of our patients, really 5 days is probably all you need for a cellulitis. And the rationale for that is because most often this is caused by a strep. Strep is a very wimpy bug. And so after a couple of doses, you know, we've killed off the majority of that bacterial infection. The problem is we've killed that infection, but it's not going to look significantly better, right? The damage is already done. The toxins have already been released. The inflammation has already happened. And so it's going to take time for that skin to repair itself. So it's not going to look phenomenal even after we've treated the infection. And so knowing that and setting that expectation is important with your patients. And so what is the treatment approach for cellulitis? So I'll kind of give you what my treatment approach is. And it mimics, I think, what the guidelines would say. We have a PPO that we use in Regina for how to treat skin and soft tissue infections. I think I take a bit of a different approach, and so take from it what you will. But in my mind, I think if we have a cellulitis, I think there's two questions that you need to ask yourself. And one is, does this patient need to be on oral therapy or IV therapy? And that's really going to depend on how they present and how severe they are. The other question you need to ask yourself is, do I need to cover MRSA in this situation? And so in situations where it is appropriate to maybe add MRSA coverage, you know, would be cases if they've had a prior MRSA infection or prior colonization, if they have the presence of risk factors for MRSA, so recent hospitalization, recent surgeries, IVDU, that sort of thing. If the cellulitis is in close proximity to an indwelling device, like maybe they have cellulitis surrounding, you know, a prosthetic joint, and in that case, they'd be very high risk of complications, you know, if that infection seeds that joint, or if they have systemic signs of toxicity, you know, and we just can't afford to be wrong. You know, these would all be situations where MRSA coverage would be reasonable. If we're not worried about adding MRSA coverage, then there's only really 2 antibiotics that you need to remember for a cellulitis, in both non-purulent and purulent, and it's cephalexin and cefazolin. And that's because in non-purulent and purulent, you know, you're worried about strep, and then in purulent cases, you're worried about Staph aureus, and cephalexin and cefazolin cover our strep organisms and our MSSA very, very reliably. And so those are the 2 that you need to worry about. If we are worried about MRSA, and if they can tolerate oral, then you can look at things like maybe Septra or doxycycline, but just know that those options won't reliably cover strep. Okay, so I mean, if it's truly a purulent infection, then we are probably more worried about Staph aureus. And then, so then in that case, like I said, cephalexin in most cases is probably your go-to. But then if they have those MRSA risk factors, then looking at Septra or doxycycline. If they're requiring IV MRSA therapy, then vancomycin is our go-to for that. And that'll cover our strep as well too. So those are kind of the 2 questions I ask myself, IV or oral, and am I worried about MRSA? If I'm not worried about MRSA, cephalexin or cefazolin are your 2 that you need to, are your 2 antibiotics that you need to know, because it'll cover the organisms that we're most commonly worried about. Now, certainly if this is a patient who is critically ill or the skin and soft tissue infection is very rapidly progressing, then in that situation, we want to cover gram positives, we want to cover gram negatives, we'll probably want to cover anaerobes. And so putting them on tazocin in those situations is completely appropriate. Chances are they'll probably have risk factors for MRSA, or we'll want to add MRSA coverage because we're not going to be wrong if they're critically ill, right? So if we wanted to be very aggressive and do tazocin and vancomycin up front while this patient, is very critically ill, that's reasonable, but just making sure that we're reassessing that therapy after 48 hours and then stepping back if the patient's clinically improving, because we know that the combination of tazocin and vancomycin is more nephrotoxic than either therapy alone. And so we don't want to be exposing that patient to potential harms unnecessarily. So making sure if we are being aggressive up front, that's usually in a select few patients. That's not going to be the majority of the patients that we see, and making sure that we're reassessing that therapy. So for the monitoring piece, I think it's very important to, like I said, communicate expectations with your patients. And so when you have someone coming in with a cellulitis, often you'll see nurses kind of mark out that border, right? And it's very common to have initial, or what you can see sometimes is have initial worsening of that erythema following initiation of appropriate antibiotic therapy. And that's just due to, because once we start the antibiotic therapy, we're killing off the bacteria, and then that bacteria is releasing the toxins into the tissue, and that's causing an inflammatory response. And so when we're killing the bacteria, as I said, you might see that redness kind of extend beyond those borders, and that's common. And that doesn't mean that that is necessarily therapeutic failure. Okay, so just to be aware of that. What we should see, though, is symptomatic improvement within the first 24 to 48 hours of appropriate antimicrobial therapy. So, the patient, after we start antibiotic therapy, even if we see that red border kind of extending, if the patient's saying, I actually feel better, the pain is reduced, I have a little bit of an appetite back, that sort of thing, that's what we're looking for. There should be some sort of symptomatic improvement when we're initiating antibiotics. So as I said, the visible improvement of clinical manifestations kind of lag, and so that can take up to 72 hours to start to see the redness kind of go down and whatnot. If you have persistence of the erythema or persistence of systemic symptoms after that period, like after that 72 period, then that really should prompt consideration of resistant pathogens or alternative diagnosis. So once again, making sure that we're reassessing the patient after 48 to 72 hours. And certainly if we start the patient on IV therapy because they have a more serious or severe presentation, then reassessing in 48 to 72 hours to see if we can step down to an oral option to complete the course. So please, if someone comes in with a cellulitis and you diagnose it and you think this is more of a moderate to severe case and you start them on IV cefazolin, you don't need to complete that, that 5 to 7 day course of IV cefazolin. If after a couple days they're improving, there is no reason why we can't switch them to cephalexin, right? Why would we keep that IV in when we could be exposing them to secondary line infections, and it's incredibly uncomfortable to have that IV in. So making sure we're reassessing and stepping down to oral therapy when they are clinically responding. And then once again, kind of, communicating with your patient and knowing that you're not going to see full resolution of the skin even after we've treated the infection. So as I said, the damage is already done, the toxins are already released, that inflammation process already started. And so even after we kill the bacteria, it's going to take time for that skin to repair itself. And so communicating that to your patient is very important so you can manage their expectations so they're not, questioning you and being like, this looks terrible, what's going on? Do I need to be on antibiotics longer? And then that doesn't put the doubt in your mind to be like, maybe I do need to extend duration of therapy to 2 weeks. It's like, no, we've killed the bacteria, this is expected. And when I was rounding with one of my ID physicians, when she went to go speak with her patient, we were treating a cellulitis, and she had said, we're only going to give you a 5-day treatment course, but know that your skin is not going to look great. It's going to take time for it to repair and heal itself. So treating a cellulitis is very much like putting out a forest fire. Once you've treated the infection and put out the fire, the damage is already done. We've got rid of the infection, we've got rid of the fire, but it's going to take time for that forest to rebuild itself. It's going to take time for that skin to heal itself. And so telling that patient that up front, helps manage their expectations and they know what to expect moving forward. So in summary, the most common cause of cellulitis is our beta hemolytic streptococci in our non-purulent infections, Staph aureus in our purulent infections. It's almost always unilateral, so if it's a bilateral presentation, think of an alternative diagnosis. The duration of therapy for the vast majority of patients is probably your 5 days, maybe 7 days, and that's because, like I said, strep is very easy to kill. Reassess the patient after 48 to 72 hours to ensure that not only are they clinically improving, but also to consider IV to PO step down if we started them on IV initially. And then communicating that we're not going to see the full resolution of skin even after we've treated the infection. So once again, I think I'll break there before we move on to the last topic. And I will see, is there any questions on cellulitis? Okay. Okay, we're going to move on to the last topic. This is my favorite topic, actually. So we're going to talk about Staph aureus bacteremia. And why is this such an important topic? Well, one, Staph aureus bacteremia is a leading cause of community-acquired and hospital-acquired bacteremias, and it has a very high mortality rate associated with it. So mortality rate as high as up to 40% in some literature. We did a retrospective chart review where we looked at our mortality rates. Mind you, it was specifically with Tazis in use, but our mortality rate was around that 20% too. So a very high mortality rate associated with it, which is why this is such an important topic. There's lots of information showing that infectious disease consultation is associated with better outcomes, like lower mortality, fewer relapses, lower readmission rates. So in Regina, we try and make it an automatic ID consult when we have a Staph aureus bacteremia. So I get printouts of patients in Regina and surrounding areas of all of our Staph aureus bacteremias, and between myself and the infectious disease physician, we make sure that we go and review all of these patients because, because it's such an important step to take to reduce that mortality rate. So what does this diagnostic evaluation look like? So I think the most important point that I want to get across is that Staph aureus bacteremia is never ever considered a contaminant. So I've had conversations with physicians where we'll find a Staph aureus in the blood and they'll be like, yes, but it's a skin organism, it could be a contaminant, it was only present in 1 and 2 sets. And that is never the case. So I just want to kind of get that point out there. Staph aureus is not like Staph epi. If we find it in the blood, it's clinically significant and we need to treat it accordingly. And so when we find it in the blood, it's very important to determine that source of the bacteremia. So do they have a recent cut or recent skin infection? Do they have any prosthetic devices, that sort of thing? Trying to get to the source of this bacteremia. And then it's very important to inquire about metastatic infection because that can occur in 1 in 3 patients. And so, like kind of doing your head to toe, when we find in the blood, doing your head to toe assessment, asking about headaches, which maybe could indicate septic emboli, asking about bone and joint pain or back pain, which could indicate maybe an epidural abscess or an osteomyelitis, those sorts of things to kind of see if it has seeded itself anywhere else. When we find it in the blood, it is very important that we're repeating blood cultures every 48 hours to ensure that we've cleared the bacteremia. And I say for times 2 sets. So if they don't have any indwelling lines, 2 different peripheral sites is appropriate. If they do have an IV line, making sure, particularly a central line, making sure we're doing 1 set from the central line, 1 set from the periphery, because depending on that time to positivity, that lets us know if the source of the infection is the line or if there's something else causing that infection. And persistent bacteremia is associated with increased mortality rate. And so the longer they're bacteremic, chances are the higher, actually studies have shown the longer they're bacteremic, the higher their mortality rate. So it's very important to ensure that they've cleared that bacteremia. And everybody gets a transthoracic echocardiogram. And so when we went and did our audit, we found that only 50% of our patients, and this was like a couple years ago before we made it an automatic IV consult, we found that only 50% of our patients actually had a TTE done, which was kind of eye-opening for us because we're like, everybody should get a TTE at the very minimum. And that's to rule out endocarditis, right? And so If that TTE is negative, then you can pursue a TEE if you have a strong clinical suspicion of an endocarditis. So these would be in patients, the TTE is negative, but they have persistent bacteremia, they have a short time to culture positivity, they have an unknown duration of bacteremia, so that'd be more in the setting of a community-acquired bacteremia, for example. If they have a presence of cardiac prosthetic materials or any predisposing valvular abnormalities, or peripheral stigmata of infective endocarditis, like for example, those Janeway lesions or those Osler nodes. Stephen can comment more on that. But if they're having any signs that, there might be, or you hear a murmur on the examination, that sort of thing, then you would pursue a TEE if the TTE is negative. But everyone should have a TTE to rule an endocarditis, and then pursue a TE if there's a strong suspicion for an endocarditis. And then any additional diagnostic imaging should be tailored to findings based on your history and physical exam of the patient. So the management of Staph aureus bacteremia, source control is our cornerstone of management. There's a study that showed that basically patients with delayed source control had prolonged bacteremia, and each day of bacteremia was associated with a relative risk of death of 1.16%. So the longer they're bacteremic, the higher their mortality rate, which is why it's very important to try and identify a source. And we don't always identify a source, but we really should try, and kind of go through that thorough patient history to identify where this could be coming from. And then obviously we use appropriate antibiotic therapy, which we'll get into. We're making sure we're following up with our cultures and investigations, and that we're putting these patients on appropriate durations of therapy. So our antibiotic treatment is really going to depend on if it's empiric versus targeted therapy. In Regina, we have the Gene Expert. Do you guys have that here in Yorkton? So, yeah? So you get your results within 24 hours most often? Maybe, maybe not.
No, we go to Regina, right? Yeah, but they'll identify on a gram stain at least if it's staph, I think, right? Is what they'll tell us.
But you won't know if it's MSSA or MRSA within 24 hours?
Not till the 5-day mark.
Okay, so in Regina, like if we have a staph in the blood, we'll get to find out from our Gene Expert test if it's an MSSA or MRSA within the first 24 hours for sure. And so that makes it easy for us because then we can tailor therapy right off the hop. So then in cases where, it's a staph, but you don't know if it's an MSSA or MRSA, then obviously you're looking at your MRSA risk factors, which I kind of had went over before. So I'll say, if you are worried about an MRSA infection, what's recommended is you start off with either cefazolin or cloxacillin. But if you're worried about MRSA, you add vanco on top of that. And the rationale for that is there's studies that show basically vancomycin is a crappy drug for Staph aureus bacteremia compared to cefazolin and cloxacillin. And there's studies that show that patients who are started on vancomycin monotherapy for a Staph aureus bacteremia, if that grows out in MSSA, those patients actually have worse outcomes than someone who was started on cefazolin plus vanco right off the hop. So if you have a Staph aureus bacteremia, give them cefazolin or cloxacillin, but if you're worried about MRSA, add the vanco on top of that. When you find out that it's just an MSSA, then get rid of that vanco. So that would be the treatment approach that we would take. And in Regina, we do have, because this is such an important topic, we do have a pre-printed order set that walks. Basically, it has the blood cultures ordered every 48 hours, it has the echo to be ordered, and it has your treatment recommendations as well. And so it kind of walks you through, when to add cefazolin, when to add vancomycin. And so we can certainly share that with you guys if that's something that you're interested in, because it is, a lot of physicians use it and they find it very helpful. Yeah.
Actually, in your experience, do you recommend the empiric coverage for some of these patients with MSSA and MRSA? Because down here, we normally get the blood culture maybe 3 days after, So usually we have to be proactive. We have to cover it empirically.
Yep.
We have to wait for the blood culture. At the same time, what group of patients, what demography of the patient, their baseline characteristics that we can highly suspect this, so that we can cover them empirically in their experience.
Yeah, so
IV drug use, dialysis patient, and all those kind of patients. And the other group of patients that we may suspect this type of infection and cover them empirically while we wait for the culture.
Yeah, so the patients, you listed off obviously some of the risk factors. So the patients that I would cover empirically for MRSA, or I would add vancomycin onto my cefazolin or cloxacillin regimen, would be, prior MRSA colonization, or IVDU population, or dialysis patients, if they've had, a recent hospital stay within the last, 3 to 6 months, if they've been put on broad spectrum antibiotics within the last kind of 3 to 6 months. Those are some of the patients that I would be maybe more concerned about MRSA, or maybe even sometimes our long-term care patients, depending on how sick they are. That's not always a risk factor, but it can be certainly. So, but those are some of definitely the common situations where I would empirically add vancomycin onto my cefazolin or cloxacillin. So for MSSA, when we have more targeted therapy, really cefazolin or cloxacillin are completely appropriate. One isn't superior over the other. They're both equally effective. We tend to go with cefazolin because it's Q8 dosing versus Q4 dosing, so it's a bit of a courtesy thing to the nursing staff. In situations where we'll choose maybe cloxacillin is if a patient has unstable renal dysfunction, their GFR is kind of fluctuating all over the place, then we'll do cloxacillin because you don't need to renally dose adjust. Or if we're worried about any potential CNS involvement or maybe septic emboli to the brain, then we'll do cloxacillin because it has better CSF penetration. For MRSA, obviously, our go-to is vancomycin. If we can't use vancomycin for whatever reason, guidelines, and we would recommend daptomycin, but knowing that you can't use daptomycin if there's a primary pneumonia because it gets inactivated by the pulmonary surfactant. And if you can't use either of those, then you really should be consulting with an infectious disease physician, because then it gets very tricky. I mean, linezolid, the guidelines would suggest that daptomycin is the appropriate second option if you can't use vancomycin. I don't know what your availability of daptomycin is here. It's not something I wouldn't routinely use linezolid if I couldn't use vanco. My preference would be daptomycin. Stephen, do you have any comments on if they couldn't use? I mean, linezolid is a good substitute for vancomycin in certain situations, but certainly I think the evidence and the guidelines would say that daptomycin is probably a more appropriate choice. But at the same time, you have to go with what you have. And if you don't have access to daptomycin, then linezolid is an appropriate second line option in that case. Stephen, would you agree?
Yeah, I think so. I mean, I think that I think that it'd be important to try and get access to Dapto. Like if there is no access to Dapto, then it might be a good thing in terms of pharmacy to just try and have some storage of Dapto so that you guys are ready. I mean, it doesn't happen that often, right? But I think that if you guys can't, yeah, I think that's just an important drug to maybe stock, especially Yorkton, which is kind of more of a regional center.
It is stocked, but has to go through ID consult for use.
Okay. Okay, so if you can't use vancomycin, really the preferred option for a bacteremia is daptomycin. And so making sure that if you're needing to use it, then you can certainly call the ID doc, I guess, to get approval for that.
Very few indications.
Actually, just to correct, I don't think Dapto is a ID. I don't think there's any drugs that are restricted, and so I think that I don't think that's something you need ID approval for.
Dapto is a restricted agent, Stephen. It's probably like the only restricted agent that we actually really abide by.
All right, sounds good.
Okay, so moving on to duration of therapy. So anyone with a Staph aureus bacteremia has bought themselves a minimum 14-day of therapy. And this is for, like I said, this is minimum for uncomplicated bacteremia. And so it's considered uncomplicated if they don't have any endocarditis, there's no indwelling devices, such as prosthetic heart valves. This includes things like vascular grafts. So if those are not present, then more so uncomplicated. It's uncomplicated if we clear their cultures after 2 to 4 days, if they defervesce within 48 to 72 hours, if we've removed the presumed focus of infection, and there's no evidence of metastatic staph infection. Otherwise, if they don't meet that criteria, it's considered complicated, and you treat for anywhere from 4 to 6 weeks. So 6 weeks is more so for an osteomyelitis or an endocarditis. I would use a 4-week duration in patients where we've ruled out deep-seated infections like an endocarditis or an osteomyelitis, but this patient just took a week to clear their bacteremia. So in those cases, I would treat for about 4 weeks. So in summary, and to wrap this up, Staph aureus is never considered a contaminant. It's very important to identify the source of the bacteremia and obtain source control if feasible. Making sure we're repeating blood cultures times 2 sets every 48 hours until clearance. everybody gets a TTE, and then you pursue a TEE if the TTE is negative and you've got a strong clinical suspicion for endocarditis, and minimum duration of therapy is 2 weeks of IV antibiotics. And this is a situation where we do recommend 2 weeks of IV. There is maybe some data that says in some cases you could do oral, but I'm certainly not making that recommendation. There's not enough evidence to support that use. So I just want to quickly go over, I found this paper that talked about top myths of diagnosis and management of infectious disease in hospital medicine. This was published in the American Journal of Medicine. And in this article, they mentioned that 30 to 50% or more of our inpatient antimicrobial use is either unnecessary or suboptimal. And they kind of go behind this, they talk about the psychology behind prescribing and why they think that we see some of this. And so they talk about all the different myths. And so I'm not going to go over all of them, but some of them that I pulled out was, that antibiotics carry some potential, but very low risk of harm. Well, we know that that's a myth. Reality is antibiotics are the second most common cause of adverse drug event-related emerge visits. We know that there's studies that show that each day of antibiotic therapy increases individual risk of C. diff by 9%. So they do cause harm. The other myth is that longer antibiotic courses are more effective, when in reality we've got lots of clinical trials, lots of data that's showing that short course therapies for a variety of different infections are actually equivalent to longer durations, as is the case. You can get away with 3 to 5 days for community-acquired pneumonia. You can do a 5 to 7 day course for a pyelonephritis, which we talked about, 5 to 6 days for cellulitis. We don't need these long durations of therapy, and so that's very much where I think antimicrobial stewardship is moving. Like Jason said, there's certain situations in outpatient settings where it's like you can only do what you can do, right? But things that we can improve on are things like shortening our duration of therapy, maybe being more selective with our antibiotics, narrowing spectrum, stepping down from IV to oral. These are things that we can do very confidently, and that's very much practicing antimicrobial stewardship. The other myth is that IV is better, and once again, lots of data that shows that some even very serious infections can be successfully managed with a step down to a highly bioavailable oral agent. So there's cases for like a chronic osteomyelitis, or in some cases an infective endocarditis, although this would be a very small subset population, and truthfully we haven't really done it before. But there are studies that show, even in our deep-seated infections, like even our gram-negative bacteremias, from a urinary source, you can start off with IV and step them down to an oral agent if they're clinically improving. So IV is not always better. Oral antibiotics have numerous benefits, including prompting readiness for earlier discharge. It reduces the risk of IV catheter infections and associated complications, reduces costs, reduces workload. And as I said, I've had an IV, and I'm sure lots of us have. It's incredibly uncomfortable. So why would we want our patient to have that IV sticking in the arm when we can easily step them down to an oral option? So our take-home message, wrap this all up, treat the patient, not the lab result. Longer durations are not always more effective. IV is not always better. Antibiotics are not benign. They contribute to resistance. And so because of that, very important to know your local antibiogram and be aware of your local resistant patterns. It's very much going to guide your empiric therapy. And antimicrobial stewardship is a multidisciplinary approach. This is not about the physician needs to do better, the physician needs to do this. No, that's not the mindset at all. It's, we're a team. This is a global issue. We need to support each other in making, the best treatment choices for our patients to improve patient outcomes and to reserve this global resource of antibiotics. So this is very much a multidisciplinary team approach. So I will end it there. That is the end of the presentation. Thank you guys very much for your attention, for your interactions, for listening, for your questions. I guess if there are any further questions, we can address this now. Otherwise, once again, thank you for inviting us and thank you for listening.
I do have one question. Staph bacteremia.
Yeah.
IV.
Hello.
And then step down to oral to prevent rebound infection. Is there any data on that?
Okay, so the question is for Staph aureus bacteremia, starting off with IV and stepping down to oral to prevent a recurrent or a rebound infection or a reinfection. I would say probably not. I guess it depends on what the situation is. So if you're, and what the source of the infection is. I would say for a Staph aureus bacteremia, where, once again, it depends on what the source is. If it's Staph aureus bacteremia and there's an underlying endocarditis, you're going to treat them for the 6 weeks.
So this was an uncomplicated, like in 2 weeks of IV.
Yeah.
But then the recommendation was to send on the oral for like another 3 weeks
And what was the rationale for that?
to prevent, I think it would like to prevent this recurrence or rebound.
So I would say we typically definitely do not make those recommendations. I don't think, I'm not aware of evidence that would maybe support that type of practice. And so maybe this was a very specific case, but we usually don't see that type of practice, at least in Regina.
I'll say it came from vaginas.
Okay,
That's why I just
Is it like osteomyelitis or do you remember what the?
interesting. Okay, well I mean, I wouldn't be making that recommendation. I don't know of any evidence that would support that recommendation. Stephen, can you comment on that? If someone had an uncomplicated Staph aureus bacteremia, they had 2 weeks of IV therapy, is there any evidence that you're aware of where you would step them down to oral therapy to prevent a recurrence or something for another 3 weeks?
And not that I know of. There might have been some specific circumstances, like Mel said, that may have dictated that case. But in general, no, I've not heard of any evidence to do that.
I have a quick question.
Yep.
So it takes it can take up to 5 days to get a culture back.
Okay.
And
Yep.
I did see that, you're supposed to take your blood cultures every 48 hours and a staph. But if you have a very, very strong clinical response, somebody's, febrile, white cells, 25, very, very ill, and within like 24 hours, whites drop to 10, fever's gone, do you still do the repeat cultures? Do you still do all of that process irregardless?
Yeah, I would. Yeah, absolutely. And I think that's certainly what the evidence and the guidelines would suggest and recommend, because we do want to ensure that we're clearing that bacteremia. Because I mean, even if it comes back, growing out in 2 sets after, 18, 20 hours, maybe the next set, it might clear, it might not clear, but it kind of gives you an idea. It might change what your duration of therapy might look like. I mean, so it's obviously a very good sign that the patient's clinically responding. And that's usually, a sign that if they respond that quickly, then maybe there isn't like a more deep-seated infection, but I think it's still very important to maybe conduct those investigations and rule that out specifically, because Staph aureus is such a virulent organism and it's such a sticky bug, and it likes to seed all different kinds of places in the body. And so I think it is important to carry out those investigations to ensure that we've cleared the bacteremia and ensure that, it hasn't latched itself onto our valves and whatnot. Stephen, would you agree?
Yeah, I would.
Okay. Yep.
One more question. What do you do with an outpatient that's positive Staph aureus? I mean, do you send them to the hospital for an IV or do you put them?
So there has been a couple cases where I've had a patient who came back with Staph aureus bacteremia and they were an outpatient. And in those situations, there's someone from Emerge or even myself, we've tried to actually reach out to the patient and get them to come back to Emerge and at least start them on IV therapy and then repeat the blood cultures and then at least order an echo. And then in those cases, where, surprisingly, they're well enough to be out in community, which doesn't happen that often because usually these patients are quite sick. But if they are well enough to be out in community, then we start the process of kind of outpatient home IV therapy, or in some cases, these patients might just come in and get their doses and Emerge, but I mean, they would have to come in 3 times a day, so that's not really ideal. So we certainly do initiate kind of the outpatient antibiotic therapy. But usually these patients will come in, they'll stay in hospital probably for like 24 hours, whether they actually get admitted. I don't know if that always happens, but they'll come in, we'll start them on IV therapy, we'll repeat the blood cultures, we'll get that TTE ordered, and then we'll go from there.
Since we have an ID doc here that I can bug about this, so if 30% of cases seed elsewhere, I'm just thinking of my number of patients with headaches and joint pain. How much looking do you go to look for that metastatic seeding?
So Stephen, I'll let you jump in and answer that one.
I mean, I think it depends on your clinical scenario. Like, I think your echo should be done. And then yeah, your echo should be done, and then I think everything else is kind of, I mean, a lot of this stuff is like your clinical gestalt, I think, and your clinical assessment of it. And, certainly, yeah, I mean, I guess you could always get internal medicine involved locally to help out as well. But like, I think it's really your clinical gestalt. I mean, I usually do an echo and then just kind of see what happens, but it really depends on your clinical gestalt.
Okay, thank you.
But I think certainly if the patient is, complaining of an ongoing headache and there doesn't seem to be any other, cause or explanation for it, then, ordering other investigations like maybe a CT of the brain or something to rule out a septic emboli is probably completely appropriate. And I mean, too, if they've got a left-sided endocarditis, and they're and we've confirmed that with an echo, and they're complaining of a headache or they're complaining of back pain, very likely that it's possible that it could be seeding itself to other areas, right? So just piecing all that together and ruling out emboli to the brain is important, because if you had chosen cefazolin up front, for example, well, you might want to, if we're worried about septic emboli to the brain, you might want to switch that to cloxacillin to ensure, better CSF penetration. So hopefully that answered your question.
Yes.
Okay. So just looking at the question box, we kind of already answered if linezolid's a good substitute. So someone had asked, how about urine culture showing Staph aureus? Same treatment, question mark. And so in that situation, as I kind of said before, if we're finding Staph aureus in the urine, in most cases, that is it could be very much a descending pathway. I mean, in some cases it could be ascending, but if we're finding Staph aureus in the urine, you need to worry that this is a descending pathway, and you need to worry that this is maybe a bacteremia that's now seeded into our kidneys. And so if we find Staph aureus in the urine, at least my approach, I would be probably doing a blood culture to rule out a bacteremia. And if you do rule out a bacteremia, I've seen Staph aureus urinary tract infections where it was ascending because they tried to insert a catheter, and it was maybe a more traumatic insert, and happened to carry that bacteria up into the bladder via the catheter insert. And so in that case, then it's like, well, then you would just treat the staph in the urine with, your cefazolin or cephalexin or whatever that looks like after you've ruled out the bacteremia. Yep.
Once you've got your gene expert report that says it's MRSA and you have them on cefazolin and vanco, you can drop the cefazolin at that point?
Oh, yes. Yep. Yep. Yeah, if it's a confirmed MRSA and we know that it's a confirmed MRSA, then yeah, dropping the cefazolin. It was really the studies that show that, we've got a staph in the blood. And so the patients who were started on vanco versus vanco and cefazolin, and for the ones that grew out an actual MSSA, the ones who were just on vanco monotherapy had poor outcomes because vanco is slowly cidal and not as effective as a beta-lactam for an MSSA. And so those patients who are on vanco monotherapy for the MSSA infections had poorer outcomes, which is why we recommend adding vanco onto cefazolin or cloxacillin. But for MRSA, you can drop a cefazolin, yeah. Okay, I don't think there's any more questions. Once again, thank you very much for listening. Thank you for your interaction. I hope we touched on some of the things that you guys were hoping to learn from us. And certainly if you have any other feedback on what you as physicians or clinicians would like to hear, if you're more concerned about, dealing with certain outpatient settings, you can bring that forward to your antimicrobial stewardship team, so either Marcy or, Kelsey or Tanya, and we'd be happy to come back and give another talk